blockers, and you know class 4, which are your calcium channel blockers. Okay, so the same stuff that you learned is coming back into this lecture too, okay? So when you're looking at this, just understand that a lot of our drugs that we have on board are going to work on the ions that are controlling the conductivity of the heart, like our rhythm. So when we look at some of these meds, we're going to try to look at them and say, how can I use them to benefit my patient, to help them not have that rhythm being out of sync? Okay, how can I control their arrhythmias? So what we saw was they had a trial called the CASH trial, or cardiac arrhythmia suppression trial. And what you can see is that some of our patients who were on medications, they do have benefits, and we are decreasing morbidity and mortality in those patients. And some of our medications that we treat arrhythmias with are pro-arrhythmic, meaning they cause arrhythmias. Okay, so it's kind of like a, well, why would I give this med if I know that it can still cause this thing? We're monitoring the patient most of the time. Like I tell you, with most of your side effects, you may not experience every single side effect that's listed, but it's something that we're monitoring to make sure that your patient doesn't have it. And with that monitoring, that tells you, bless you, that most of our drugs are narrow therapeutic index drugs. Okay, so anytime we see that narrow therapeutic index drug, we know that we have monitoring, right? Because I have to make sure that it falls within that window that it's supposed to be in. So these drugs require a lot of maintenance. Would you be prescribing these? Likely not. They'll probably be seen by cardiology, but you will have patients who are on them, and they have lots of adverse effects and drug interactions that you need to be aware of. That is where you're going to come into play when we're talking about a lot of these medications. Because something else that you could be prescribing could make that narrow therapeutic index drug now be a toxic drug, right? So you have to know what you're looking at. And then our classification of them, so their Vaughan-Williams classification system are going to be those different classes that we talk about when we're looking at these antiarrhythmic medications. This is, again, just showing you kind of what those action potentials look like. Not going to be tested over that. But looking at this, you will see this. Again, this slide and the next slide is a big summary of what you're expected to know when we start talking about these drugs. Okay, so when you're looking at this slide, pay attention to what is in the box. Again, this is just our naming convention for when we're talking about our antiarrhythmic drugs. So you see that we have 4 classes, class 1, class 2, class 3, and class 4. Class 1 has 3 subclasses, A, B, and C. So you see that all of your class 1 are sodium channel blockers. Your class 2 are beta blockers. Class 3 are potassium channel blockers, and your class 4 are your calcium channel blockers. Okay? So 4 classes. And the way that you can look at this and the way that you can kind of remember it, we're going to talk about this on the next slide, but McDonald's, laughs, because remember our beta blockers in an LOL, at bananas, potassium, okay, and milk, calcium. So you can remember your 4 classes, because McDonald's is salty. Salt, sodium, right? So sodium, beta blocker, LOL, potassium, your banana, calcium, your milk, okay, so that you can remember what your classes are. Don't worry about all of this other stuff. If you want to see it, you can. When we go over our mechanisms of action for the drugs, it's easier for you to see it there, because if you're asked the mechanism of action, I'm going to pull it from that slide, not from this slide. Okay, so that's why I just have the class and your mechanism of action in the square here. On this slide, what you're looking at is your class, again, the agents that you have, and then how do we use them. Again, that utility, you're going to also see this when we're looking at the slide for the actual drug. Every drug that is listed here may or may not have a slide, so also be prepared for that when we're going through this, like always. So now, we talked about McDonald's here, LOLs, at bananas, and at our milk. So going through this, I'll tell you a way that you can kind of remember the drugs that go in here, because you need to know which agent falls into which class or subclass. Okay, so you need to know, hey, which one of these is a 1A drug? I could just simply ask you that. I could simply say, hey, which of the following is a potassium channel blocker? Boom, you need to know, okay, what are my drugs that fall into the potassium channel blocking class? Okay, so to remember your 1A, because in 1B, 1C, remember these are all the same. So we're at McDonald's, we pulled up, and you're trying to place an order for somebody, and you call them, and they're like, what do you want? So they say, I want a quarter pounder, so quinidine, and your disopromide, okay, with lettuce, lidocaine, mixellitine, and mayo. And fries, please, so that you can remember all of these, and it's 2 per thing that you're going down, 2 per subclass that you're going down, okay? So your quarter pounder with lettuce and mayo and fries, please, are all of your calcium channel blockers. Your beta blockers, we've already talked about these last block, right? So those are all of your ones that are going to end in LOL. There is one that has properties of class 2 and class 3, but we classify it in class 3. So pay attention to your sotalol, right? Your sotalol is in class 3. It is not in your class 2 with all of your other beta blockers. It does not mean that it is not a beta blocker or that it does not have beta blocking activity, but when we're looking at our antiarrhythmics, we're seeing a lot more of that potassium channel blocking, so that's why we have it with our potassium channel blockers, okay? So that's your outlier that you have for that one. And then your calcium channel blockers, you saw those already, right? We have our DHPs and we have our non-DHPs that we can look at. So these are the things that you have already seen before, these 2. So now you have 2 new classes that you're looking at, okay? This is just a summary showing you where all of those drugs work. On your slide, you should see the sotalol is crossed out. It might have shifted a little bit whenever you saved it, because I don't want you to try to put that with your class 2, which are your beta blockers. Remember that you're putting it more so with your class 3. Okay, so make sure that you're paying attention to kind of where everything is working. Again, just a quick visualization of what they're doing, how they're keeping that rhythm back into sync. When we talk about our drug options that we have, we're going to talk about rate control or rhythm control. When you're talking about rate control, it's exactly that, right? Like trying to keep them within a normal sinus rhythm. Maybe they'll have some type of exacerbation that makes their heart rate speed up, and I'll give them a beta blocker or some type of digoxin I could even use. I'll give them a calcium channel blocker. Those are my rate control medications, right? When I'm looking at my rhythm control, those are medications that are going to be those narrow therapeutic index drugs that we're talking about. Sometimes when you're initiating them, you might need to put your patient in the hospital when you're starting those, because they can be pro-arrhythmic and you might need to monitor your patient whenever you start these medications. So if you have to choose between the 2, it's not that one is better than the other. It just kind of depends on what's going on in your patient. You also see remodeling. When we talk about remodeling, essentially what happens, your heart is out of sync for such a long time. Why it's out of sync? Several different reasons why that could be. But they can make new electrical routes, right, to cause the rhythm to be abnormal. There could be some type of blockage as to why the rhythm is abnormal, issues with perfusion, what have you. So when you see remodeling, that's something that we don't want, right? Because now that heart was working harder than we needed it to, and it got stronger. So think about you going to the gym, you're lifting weights. The more you lift weights, the more you work the muscles, the bigger that they're going to get, right? So if I do that with my heart, the same thing happens. And I have remodeling, and it tries to find new ways to try to still get that squeeze and to do its job, right? Circulate my blood, make sure that I'm alive. So your heart will compensate. And you'll look at more things about that. But from here, what I want you to know is that you have rate control, you have rhythm control. One is not better than the other, okay? Looking at our class, so we're going to go over our class 1. Whenever you're looking at this is the one that has the 3 subtypes, right? So you have 1A, 1B, and 1C. But when we're looking at this, your mechanism of action is going to be blocking that sodium channel blocker. When you're looking at those subtypes, they have different types of mechanisms. I'm not going to get that detailed. I'm not going to put like a 1A and a 1C and tell me the difference, because there's minor differences, but I'm not just sodium channel blocker, right? She's basic. So remember sodium channel blocker as your mechanism for all of your class 1 drugs. What I'm meaning is, you see this here, it says sodium channel blocker, inactive sodium channel blockers, potent sodium channel blocker. I don't care about that. Sodium channel blocker, okay? And then you see here what we were talking about, rhythm control, right? Rate versus rhythm. One is not better than the other. And then we have our subdivisions that I talked about, 1A, 1B, 1C, but I just want you to know, class 1, you have those 3 subtypes. All of the mechanisms are just going to be sodium channel blockers. So when you're looking at your 1A, what this is doing, this is your quarter pounder, right, that we had. There was another drug that used to be on the market. They removed it, so that's why the P is not there for it to help you more. But your quinidine and your disopramide, when we're looking at this mechanism of action, sodium channel blocker, and then here, making sure that if our patient has HFrEF, that we're going to try to avoid using this medication because this is going to further slow things down for our patient, okay? And we don't want to exacerbate them anymore and potentially push them to where they're having acute decompensated heart failure, okay? So make sure that you're looking at this when we're talking about HFrEF because a lot of our patients who have HFrEF will likely have this medication on board. And then you see anybody who has any type of decreased cholinergic activity. So last semester, what we talked about, right? Our acetylcholine is low in our patients who have Alzheimer's disease, so we could potentially have an issue where we can make it worse for our patients with those decreased cholinergic activity type diseases. And then your increase in your ventricular response, right? So this is what I was saying, where some of these drugs that we have that are older, like these rhythm control drugs, they can be pro-arrhythmic, they can cause more arrhythmias to occur in your patient. So just being aware that, hey, if somebody has AFib, flutter, that we need to be more cautious. And those are things that you're going to learn about as y'all continue to go through cardiology, okay? Y'all will get a heavy dose of learning the difference between all of these. So when you see this increased ventricular response, what we would do is we would put on one of our rate control medications. So your beta blocker, your calcium channel blocker, and your digoxin are the things that help with the rate, okay, not rhythm. All right, when you're looking at these medications now in a more defined way, let me go back to this. You don't need to remember anything from this. This is just letting you know that we're now focusing again on the 1A and where we're going. So quinidine was one of the first meds that we had, and we kind of built off of this and the effects and the benefits that we saw when we were giving this to our patients who had arrhythmias. So again, your mechanism of action listed here. Your clinical use is very similar to what you already saw on that summary chart that I told you to be familiar with. So your atrial and your ventricular arrhythmias. So can somebody tell me, is your atria the top part or the bottom part of your heart in your quadrants? And then your your ventricular section is at our bottom, right? I remember A comes before B is how I try to remember. So when we talk about AFib, just really quickly, the heart is kind of, I think of it as like it's quivering, right? So it can't get the full squeeze that it needs to get the blood to continue to circulate. So what happens is we'll have a residual that kind of sits and pulls in the ventricles. And when that happens, once that heart gets back into a regular sync, what did I just do with that blood that was sitting there? I pushed it, right? And if it formed a clot, I just made that person throw a clot, okay? So when we talk about this, we're going to talk about like converting a patient back into normal sinus rhythm. Sometimes you'll do different tests prior to giving them these medications to make sure that you don't have them throw a clot. We do different things, and we'll go over that, and you'll see some of your DOACs and stuff that you've already talked about pop up again, okay? With this, we're talking about this. We don't really use this drug anymore because of the increase in the pro-arrhythmic effects that we see. A lot of our rhythm control medications, you don't see us use them as much. They are still used, but not a lot. You have some cardiologists who know that they work, and they just monitor their patients very well, or if they do start to experience those pro-arrhythmic effects. Our interactions, again, just remember CYPs, okay? Inducers, inhibitors, doesn't matter. CYP interactions are going to be very prevalent. So if you see a patient who's on this medication, you're going to go to your Lexi drug, you're going to type it, pull up that interaction checker, type in the drug that you're going to prescribe or that you want to prescribe, and run it against this, and it'll pop up with all of your interactions that you'll have. Looking at your inhibitor, it's an inhibitor of CYPs as well. So again, just be aware of CYPs. What I do want you to remember from here are going to be the drugs, right? So digoxin, which we said that we could potentially use with our rhythm control meds, this level now can be displaced, and this is also a narrow therapeutic drug, right? We have to monitor digoxin levels, and we saw that you can have toxicity and different things like that when you're especially looking at digoxin. So you see here, if I'm using digoxin with my quinidine, I can see increased levels or concentrations of my digoxin, which now means that I can potentially have toxicity. Same thing with your warfarin. I'm increasing the anticoagulant effects of my warfarin. So digoxin, warfarin are getting increased if I am using them with my quinidine. Looking at my adverse effects. Outside of the fact that it is a drug that you're going to have to monitor quite a bit, you see that there are a lot of patients who are going to experience that GI upset. So nausea, vomiting, diarrhea is going to be a big thing. 30% of people experiencing something is a lot. And so again, that's one of those reasons why you don't see this used much. If I'm a patient and I'm going to the bathroom all day or I feel nauseated all day, am I going to be compliant with my medication? Maybe not, because I know that this thing is causing me to be on the toilet all the time. I don't want it. Also, looking at your synchronism that could happen, this is more likely to occur if somebody has a higher dose. The higher the dose, the more likely you are to see it. And some patients do require higher doses because we still can't control that rhythm with a normal dose. So you see all of the things that come along with that. They have ringing in the ears. They will appear more sweaty and like feeling like how we feel in this room right now. Looking at your anticholinergic properties, which is why we wanted to watch out for those patients who have already that decreased cholinergic activity, because I have anticholinergic properties that can also occur with the medication, right? So now I've just exacerbated that disease state. Anticholinergic was that wet or dry? Y'all forgot already, we just did last semester. Dry, right? Dry. So remember, I can give you anything else, and then remember what happens to their eyes, remember what happens to their heart. So all of these things can also happen. Also with this drug, if your patient has a lot of psychiatric disturbances, you can see that this can exacerbate it and make it worse for them as well. So several different things that we're worried about. You also see with that increased dose, remember these are proarrhythmic, right? So always keep that in the back of your mind. Proarrhythmic, that can be fatal to somebody if you are not around, if you're not monitoring them, if you just so happen to not catch it when it happens. Hypotension can occur, and then think about it, if you have low blood pressure, most of the time when people have low blood pressure, they may also be dizzy, right? And then you see all of this depressing of the muscles, and so in your patients who have MG, you want to make sure that you're being very cautious because their muscles are already very lax, right? And so now you've exacerbated their condition as well. And then torsades, this is a very serious arrhythmia that some of our patients can experience, and a lot of our drugs that we have can cause torsades. So there's like a list that you can print, and it has all of the different medications that have high incidences of causing torsades. So this is one of them. If somebody has hypokalemia, their electrolytes, so magnesium is low, you can see where that increases the risk, right? Because now that means my heart probably isn't going to be beating how it's supposed to anyway. The chances of me having that arrhythmia or torsades occur has now increased. And then with somebody who already has a slower heartbeat or the bradycardia arrhythmia. This is dose related, right? You saw how it said high dose. So if I see that this is happening, what am I going to do for my patient? What am I going to do to the dose? Keep it the same, decrease it, take them off of the drug. What are you going to do?
Decrease.
Just decrease your dose, right? You don't have to completely take them off of the med because they clearly need something. If you decrease the dose to whatever that minimum dose range will be, then you're like, okay, they're still experiencing these side effects. Now you're thinking of switching to a different drug. All right, disopramide. Again, your mechanism, sodium channel blocker. When we're looking at this, if somebody cannot tolerate, you can cross out propanamide. If somebody can't tolerate any of our other meds that we have on board, what we'll do is we'll say, okay, I'm going to give them now the disopramide. We don't really see this used very often. Again, another older drug. Any of our stuff that's in this class 1 is an older drug. But you see our refractory arrhythmias that we have. Looking at your adverse effects, anticholinergic effects again, think about this as a class issue, right? The same things that we looked at on the previous slides are the same things that we have here, except for your shinganism that you had before. Hypertension, and then your torsades, same things that we just talked about. All right, 1B, again, mechanism, same thing, right? Just remember sodium channel blocker. your ventricular arrhythmias or pain relief, and then you can remember that because you have lidocaine. And then your mexilotine is just an oral version of your lidocaine. Lidocaine does not have good bioavailability orally, so we give it IV only. And so, or you have topical formulations as well, but we don't give it orally. So the way to give it orally is that we'll do our mexilotine. Okay, so just think of these as two things that go together. And this is that one class that you have that's not only going to help you with that arrhythmia, the ventricular arrhythmia that your patient has, but now I also have pain benefits as well. Okay. Looking at your lidocaine, clinical use, your ventricular arrhythmias that you have. You also see that this was an alternate to our pulses VT, but I want you to remember your ventricular tachycardia. And then looking at your prevent BFib after somebody does cardioversion, we're going to talk about cardioversion, but essentially you're trying to convert that person back into normal sinus rhythm. Sometimes it works and it stays and we're perfectly fine, and then you can send them on their way. Sometimes you will convert them, and then immediately after you cardio convert them, they go back out of that normal sinus rhythm. Okay, so this is just a med that we can put on board to kind of help them stay out of that abnormal arrhythmia again. Your PK parameters that you have, we talked about the first pass effect, which is why we had the mexilotine. So this is not going to be available orally when we're talking about lidocaine. Short half-life, you also have to watch out because sometimes your patients may be fast metabolizers of lidocaine. So you'll see where you try to give them lidocaine IV or IM and they're automatically telling you already like, hey, and you're like, oh, burning through this, okay? So again, just make sure that you're aware that that is something that can happen, but you don't want to continue to just increase the dose because sometimes you can cause toxicity with giving too much lidocaine as well. Adverse reactions, least cardiotoxic that you have. Of course, if you continue to give more, you can see that occur. Your CNS issues, so you'll see like the nystagmus where their eyes are going back and forth. Sometimes you'll see tremor. But again, this patient is likely going to be in an inpatient type of setting because you're going to give it either IV or IM. They're not going to be at home doing this to themselves. Contraindication, this is if they have third degree heart block, and essentially what that is saying, and all you need to remember is heart block, but essentially this is saying like that signal that should be going between their atrium and their ventricles aren't happening, it's blocked, and so we don't want to give them this medication because it just worsens their condition and it's going to slow down things even further. And then your drug interaction, make sure that you're seeing that if you give this with amiodarone, which we're going to talk about later, that you can see increased levels of your lidocaine happen. Looking at our mexilotine, so same class, we're looking at 1B. What was that? Oh, I thought somebody passed gas. I was you need to go to the bathroom and check yourself out. Oh my goodness. Okay, sorry, that was distracted. Your clinical use, right? So your oral formulation that you have of your lidocaine. So if I have it orally, that means that my bioavailability is better. My first pass effects are going to be less, right? That's why I can use it. Used in the treatment again, same thing. Your ventricular arrhythmias, if you remember that, that'll be good enough. And then for your patients who have any type of neuropathy or nerve pain, you will see this used off-label for that. This is not a drug that I have seen dispensed often either, because we have other medications that are available with less side effects than this, so just keep this in your back pocket. PK parameters, narrow therapeutic index drug, right? We're still in this class 1. Interactions with your SIPs, so just remember interactions. Adverse effects look very common, right? The same ones that we've seen before. So your GI discomfort. Some patients, and because we do have good oral bioavailability with this drug, if they do experience those GI discomfort, I tell patients to either eat a meal, they can eat a piece of bread if they don't want to eat at that point, just something, drink milk to kind of coat their stomach so that they don't have so much upset. And then also you have antacids, just depends on what other medications they're taking. Of course, you know, some of our antacids we have to separate out. But if they're doing these things together, they should be okay. And then again, that same thing, your heart block or your contraindication. 1C, mechanism of action. What is our mechanism of action for class 1? Sodium channel blocker. Okay, so same exact thing, sodium channel blocker. When you're looking at this, your atrial and your ventricular arrhythmias, you can use this in. When we talk about our pill in a pocket approach, so what this is letting you know is that these are available as a pill, right, as a tablet. Your patient essentially will have this medication in their pocket, and if they start to experience that arrhythmia, they can take their medication and they're just terminating that arrhythmia at that point. This is a decision that is shared between you and that patient on whether or not they want to be cardioverted. Some patients will say, yes, you can try to cardiovert me, and they can stay in normal sinus rhythm, and then randomly they get out of sync, right? And they're back into that arrhythmia state. Some of your patients are like, just leave me here. I'm fine where I am. I have symptoms every now and then. So you can use things like this, which is our pill in the pocket approach, where you can give them the flecainide or the propofenone that they can use. And what they'll do is when they experience that flutter or however their symptoms present, most of the time patients can feel it, then they will take their pill and then it terminates it. They don't need to come in to see you every single time, right? Because now they're just using this as needed. So this isn't something that they're taking every single day. You see this with your A flutter potentially happening if you are trying to cardiovert someone and you don't give them the rate control. Because remember, we're still in class 1. All of these were rhythm so far. Okay? Just a picture. Don't worry about it. Looking at our flecainide. So when we're looking at our flecainide, again, your mechanism, I just want you to remember, sodium channel blocker, your clinical use, trying to maintain that normal sinus rhythm that patient has. So that should help you remember, hey, I am out of sync. I am a rhythm-controlled drug. That is what I am doing. I'm trying to control the rhythm. Important for you to remember that your patient doesn't have any structural heart disease, and we'll look at this when we start talking about the cardioversion. The structural heart disease is a little bit, you will use certain meds in those patients who have structural heart disease versus the patients who don't. Looking at your interactions, again, your digoxin level can be affected. So pay attention to the drugs that have so many interactions. When we get to digoxin, you're just going to hate that drug, but people still use it, just not as often because it interacts with everything. SIPs, again, adverse effects look very familiar. You see that you can exacerbate or cause your person who has heart failure to hit that acute decompensated heart failure stage because it's slowing down the heart rate of that patient. So if they already have heart failure, now you're potentially making it worse. They might start to hypoperfuse and all those other things, and then you end up in acute decompensated heart failure. Hypotension, A flutter, and your patients who have AFib are more likely to get that flutter again, right, because they already have AFib. And then your contraindications, your patients who have heart failure, anybody who has any type of valvular or structural type of disease, coronary artery disease, those are going to be your patients that you're watching out for whenever we're talking about using our 1C. And then this is just based off of that CAST trial that we talked about. So if somebody has heart failure or if they have had an MI, what we saw was an increased risk of death in those patients because of the fact that this medication is potent and it is a very strong medication, so they're likely to see that the bradycardia and all those things kind of get exacerbated in your patient. Okay, so avoid it in that situation. Propofenone. When we're looking at our propofenone, again, sodium channel blocker. When we talk about the weak beta blocking properties, we don't, again, classify this as a beta blocker. Just know that you're getting a 2-for-1. They're not potent enough to where we're like, hey, this is a big deal. If you have somebody that's on a beta agonist, you could see where now you need to change some doses that they may be needing. Or if you're going to be the one who's prescribing that beta agonist, you might say, hey, let me make sure that that drug, the propofenone, isn't blocking a lot of those beta receptors. Clinical use, again, we're still in our rhythm control. They still don't have any type of structural heart disease. Pill in the pocket approach. Remember, our 1Cs are pill in the pocket, right? They can take them anytime they're experiencing that arrhythmia. They don't need to come and see you after you prescribe this for them. Adverse effects are very similar. Different things that you see here is that metallic taste. And because of the beta blocking properties that you do see from this drug, you can see where all of these things can kind of become affected, right? Bradycardia, acute decompensated heart failure can end up happening. Bronchospasm, because remember from last semester when we talked about beta blockers and how we're using those in our patients who have asthma. It can sometimes cause them to have the bronchoconstriction occur. And so all of these kind of fall into that second bullet under your adverse effects. They're kind of all falling into those beta blocking properties that you remember from last semester and from last block. Drug interactions, a lot of them again, right? So your digoxin, your warfarin, SIPs. Just remember what's happening to the drug, whether it's going up, like the effects of the drug are going up or down. Don't remember the percentages, okay? Don't need you to know about the percentages. I just changed it. All right, beta blockers. We still okay? Y'all are looking like, I'm not ready for Thursday with y'all. Okay, beta blockers. How do beta blockers work? They block the beta receptors. What happens to my heart rate? Does it go up usually or down? What if I have, what do we teach you guys about diabetes with beta blockers?
Mask.
It masks those symptoms of those patients. What about my patients with asthma? Right? It can cause some of that constriction to happen for them. So, same drug that you've already seen. It will be very similar if you have a drug that we're asking about the mechanism of action. But here what you're seeing again is that it's trying to slow down the conduction, right? It wants to slow things down. So if I have some type of tachyarrhythmia, tachy is going fast, then this makes sense. So if I'm looking at that, I am now looking at a rate control medication instead of like what we were just talking about with our class 1, which were all rhythm. So now you see that I am looking at a rate. When you see your ISA agents that we talked about, remember you guys had to remember your beta-1 selective and all that, and you had your ISA. When we talk about our ISA, that was your ACE pin, right? Your ISA. When we talk about your ISA, these are the ones that are not going to bother with that heart rate and the contractility. So those you're not going to get that benefit how you are from all of the other beta blockers, whether beta-1 selector, mix. You'll see some type of cardiac issues kind of going on, that rate changing. Our ISAs aren't doing that. So that's why you see except for ISA agents there. So, rate control, right? Helping with the rate. All of these clinical uses when we're looking at our tachyarrhythmias are what we're using it for. So just, if you remember tachyarrhythmias, you should be okay. AFib is going fast also, so kind of remembering that. When you see your AFib, this is what we talked about before, while we might want to anticoagulate them, because now if I'm trying to control that rate, when they were in that quivering state, and now I've slowed it down to where they can actually get a better squeeze, I have now recirculated that blood that's been sitting there. So sometimes we'll do different things like a TEE, or we will anticoagulate our patient so that we don't make them grow a clot, and then we have the downstream effects of them having that clot. We already talked about the different morbidity, mortality effects that we have from beta blockers. You have those same benefits when you're looking at them, using them in arrhythmias. And then again, post-MI, this was one of those things that we put our patients on, right? So you're seeing the same thing here. Looking at your adverse effects, same things that you've seen before, right? Looking at your agents, you already know the difference between like your class 1, class 2, class 1, class 2. Your selective versus your ones that are mixing your paint in the lab, or your mixed action. So looking at these, this was your non-selective. So remember your selective was mainly your A through M kind of drugs. Remember how they teach you guys that way, right? So remember which ones, that's the same exact things that you're gonna see here. So non-selective, you see that we have IV, we get good penetration. So I remember propranolol, which starts with a P, penetration, great penetration, P and P. Metoprolol, very popular drug. We use it for so many different clinical indications. We have several formulations of our metoprolol, so IVPL, good drug for us to use. Remember, you have your tartrate and your succinate, so remember the salts on those because we're using those in different situations. One is a more immediate release and one is a sustained release drug. So kind of using them, that salt definitely matters whenever we're picking a drug. Looking at your atenolol that you have, again, another very famous drug a very popular drug. Esmolol, this is going to be for your patients who are going to be inpatient, right? Because your Esmolol was your one that you had that was only IV. Very, very short half-life with this. We'll talk about this drug a little bit more. And then your bisoprolol, again, one of your beta-1 selective, because remember it was in the first half of your alphabet. What drugs did y'all use for HFrEF when we were talking about our beta blockers? Carvedilol.
Metoprolol,
Just making sure you remember. I don't know if you'll see that again or not. All right. Class 3. We talked about beta blockers. Remember them. They're there. Class 3, we're now dealing with our potassium. So potassium channel blockers, we're back at rhythm control. Okay? So now you have class 1 and class 3 that are both looking at rhythm control. Okay? All of the other stuff under that mechanism of action, I don't care that you're learning all of that. Your clinical use, you see that you're having your atrial and your ventricular arrhythmias both effective, or both of these conditions can be treated when we're talking about our class 3. And then here are all of our different agents. I kind of grouped them when trying to remember. So remember, this was our oddball, was our sotalol, right? It was the only beta blocker, the solo beta blocker that was in class 3. He fell out of class 2. Then you have your amiodarone and your dronedarone. I kind of put those two together, and your ibutalide and your dofetilide. Okay? So these are your class 3 drugs that you have available. When we're looking at this, we already talked about our mechanism of action. Your clinical use, you see that we're using this in a pulseless VT, so ventricular tachyarrhythmia, and then you see your VFib again as well, so like your cardiac arrest issues. Treatment, we already talked about your atrial and your ventricular, and then preferred in our patients who have heart failure, you'll see that we use this class quite a bit. Your contraindications that come with this, you've seen when we talk about, and we'll talk about this again with some of our other drugs that come later, but contraindicated in your patients who have anything that surrounds iodine, right? So your iodine sensitivity, so when we think about that, hyperthyroidism, when we talk about the thyroid, you'll see that iodine is involved in that, and then heart block, okay? Because it's going to slow things down even more when we put this drug on board, okay? So iodine, think about iodine, hyperthyroid, your thyroid puts on your iodine moieties, okay? So think about that, and then heart block. Looking at my routes in which I have my amiodarone. Amiodarone is a drug that has been around for a while. If you end up in inpatient or doing like a cardiology rotation, you will likely see them putting somebody on amiodarone. So PO and IV, when you use the IV, which is typically what we use in inpatient, and we try to load these patients, you will see that your patient their rhythm changes pretty quickly, right? Because IV, my bioavailability is almost at 100%, right? It's going in and it's doing exactly what I need it to do. Once we load that patient, we'll sometimes switch them, we always typically are going to switch them to the oral formulation of the amiodarone, and then we kick them out of the hospital, right? This has a very, very, very long half-life. So up to 3 months after someone is taking this medication, what you can see is that they're going to still experience some of these side effects that we're going to talk about, which are a lot of things for you to monitor whenever somebody is started on this medication. You see that it's going to have CYP interactions because it's an inhibitor as well as a substrate, so lots of interactions. So when you're looking at this, I can induce several drugs. So when I'm looking at these are things that are going to help with seizures. When I'm talking about my phenytoin and my phenobarb, rifampin. When do y'all remember rifampin? Yeah. So we have that. We also use this sometimes if somebody has endocarditis, we'll have this on. And then looking at your inhibition, inhibits lots of things, right? We don't typically see this, our PGP being inhibited by a lot of drugs, and a lot of our drugs aren't substrates of PGP, but now you're seeing that here. So our statins, digoxin, warfarin, these all look like things that somebody who has a cardiac issue might be on, okay? So you'll see increased levels in those. And I'll look and see how I haven't written your exam yet to see how in depth I want you to look at this. So if somebody just reminds me to look at that so I can tell you how deep I need you to go into this. Statins, just remember statins. I don't need you to remember this max dose. Again, we talked about statins. They do have some interactions, and this was on your slide that you needed to remember on that lecture that we talked about our lipids. And then digoxin, again, this is one of those rate-controlled drugs that you could see being put on at the same time as you're having your amiodarone. So what you would do is you would decrease and monitor how you're giving your digoxin levels. Your warfarin, looking at your warfarin, again, you see that your INR can be affected if you started this medication on a patient who is already taking your warfarin. And then additive bradycardia, all of these meds, you should be thinking about this, right? If I put it on board with something else that is slowing down the heart rate, it's going to also add on to the fact that the heart rate is being slowed down. So my non-DHP calcium channel blockers, my beta blockers, I could also think about like, hey, this is going to slow down my heart even further, and I have this amiodarone on board that could also potentially cause that, okay? So we don't want to overdo it, because then your patient is going to be very bradycardic and not happy. Look at all of these side effects, right? Amiodarone has a lot of adverse reactions. When we're looking at them, you have pulmonary fibrosis, you have hepatotoxicity, you have your hyperthyroidism or hypothyroidism, so I just think about monitoring their thyroid altogether, and then your ophthalmic issues, and looking at the cosmetic thing that can happen. You can see where some of your patients, their skin will turn a blue-gray color, and then remember this long half-life, right? So even when they stop it, they're going to look like a Smurf, potentially, for a couple more months. People stop this medication because this happens to them, okay? People like how they look. It doesn't happen to everyone. It can happen. So going back up to your pulmonary fibrosis, essentially what you think about now and why we don't see as many issues with a lot of these things that we're monitoring. One, we know what we need to monitor now. But two, the doses that we use are not as bad as what we used to use before. So you're going to get a baseline PFT. You're going to get a radiograph, make sure everything looks fine at baseline, and then you will do that again every 6 to 12 months, or if your person complains of any types of symptoms, right? They're talking about shortness of breath to you. You don't say, well, it's not been 6 months yet. We'll check it, okay, to make sure that they're okay. Looking at your liver toxicity, again, baseline every 6 months. Your thyroid, baseline every 6 months. Your skin, that's just them. They're going to come and tell you about that. And then their eyes, when you're looking at this, most of the time they should be getting whatever their regular checkups are. We'll check this at baseline to make sure there's no issue, and then typically it's around a year time frame when we bring people back in, or if they claim that they're having any visual disturbances, okay? So listen to your patient, monitor them, make sure that you're bringing them back in and they're telling you that they're having some type of symptom that looks like it's an adverse effect to your amiodarone. So please be familiar with what we're monitoring when we're looking at those adverse effects, because your amiodarone has a lot of things that you need to monitor. So there's 5 things. Your genetarone. Genetarone sounds like your amiodarone, right? But it does not interfere with any of those thyroid issues, how we were talking about the iodine and that iodine allergy. We're not worried about that when we're looking here, okay? So just make sure that you're knowing that, yes, these 2 things do sound alike, but genetarone is like the improved version, not worried about that iodine moiety, not dealing with the thyroid or bothering the thyroid. So that's what this first bullet is telling you here. Your mechanism, I told you, just remember potassium channel blocker. My clinical use, you see that I'm trying to get them back into that normal sinus rhythm. So rhythm control, we know that because we're in class 3 of your AFib and flutter patients. Also your people who have a history of your your AFib. Okay, so we're using it AFib, A-flutter. When you're looking at your PK parameters, bioavailability, we like food. So don't take this on an empty stomach, right? If I give it with food, if I'm eating, now I have increased my F. I have increased my efficacy of my drug more of it available. Now, talking about that, this is very important to tell your patients because if you're going to choose this because there's less side effects and less monitoring than our amiodarone, you have to also understand that this one is not as effective, right? Because those concentrations aren't as good. So less effective than my amiodarone. So you need to make sure that you're stressing with your patient that they have to eat because you don't want to further decrease the efficacy of your drug because it's not having a high enough concentration. Half-life, not as bad, not up to 3 months, right? So a normal half-life that you see, and then again, those CYP inhibitors are going to also be in there. So, big thing with your genetarone, make sure that they're eating whenever they take this. Not as effective as my amiodarone, but the plus that I have here is that I'm not worried about that iodine issue. So I'm not looking at their thyroid. If they have an allergy to iodine, doesn't matter. Now I can give them this medication. Adverse effects. What you could potentially see is if somebody has heart failure, their symptoms will potentially be worse. Overall, this drug does not require a whole lot of monitoring like we did with our amiodarone. You can also see potentially that QT prolongation happening in our patients. So looking at this drug interactions, any of our CYPs and anything that can prolong that QT, because this medication can also prolong the QT. Contraindications. QT prolongation, they already have it, not giving it to them. I'm not going to ask you the class, I'll just put acute decompensated heart failure. So if you see acute decompensated heart failure, that's all you need to know. Don't worry about the class. Like I won't put a class one thing there and expect for you to know that. Just acute decompensated heart failure. Looking at your hepatic impairment, any debris block, any bradycardia, all those things make sense because of what my drug is going to do for me already. Sotalol. So remember, this was our beta blocker, right? Our class 2 that fell into 3. So this is your abnormal one that you have. You do see that you have some non-selective activity as well. So when we think about this and some of the adverse effects that you're going to see, understand that those are because of the beta blocker portion of this drug, that beta blocking activity that you have. Black box warning. So remember, our black box warnings are things that we take very seriously because they can kill someone. So when we're looking at the black box warning for our sotalol, what we're saying is if you decide to initiate this medication on a patient, they need to be in a facility that is able to monitor their heart and make sure that you can resuscitate them if something goes wrong, okay? So they are started on this medication, but they are monitored in a facility 1 to 3 days for that monitoring. Most of the time we keep people for 2 to 3 days. I have not seen where they kept somebody for 1 day, but that's cardiology, again, is usually the team who is going to initiate this. Clinical use, your ventricular arrhythmias, and if you're trying to maintain any of your atrial arrhythmias that you had, so AFib, A-flutter. Looking at our PK parameters that we have, so looking at this, it's not a whole bunch of adverse effects that we're looking at, interactions that we're looking at. So think about anything, if you're giving it with another beta blocker, right? Additive effects, if I was giving this with a beta agonist, I could be now diminishing the effects that I was getting from my beta agonist. Good overall. So all I want you to remember here is that it has the beta blocking effects. If you remember that, you will remember any interactions that I throw your way if it comes to that. Adverse effects, slowing things down. So you have where you can have your bradycardia that can occur, and then you can also see sometimes where our body is going to come back and you have the proarrhythmia, right? So your body could have reflex, and then you see that proarrhythmic effect that can happen. Torsades, which is why we're monitoring them and making sure that we have them in a facility for that 1 to 3 days. And that's why I said typically you don't have people who are going to only be in the hospital for a day. They keep them for a little while because, again, remember that torsades was the one that we could kill our patient, especially if they weren't with us being monitored. Your bronchospasm, again, because of those beta blocking effects, just remember all of your adverse effects for beta blocking and you have your adverse effects for this drug. Contraindication. If somebody has heart failure and is uncontrolled, right? They're not on their backbone, they're not on their medications how they're supposed to be, then you can see where this becomes a problem for our patients because now we can potentially exacerbate and send them into acute decompensated heart failure. Bradycardia, because we already said we're slowing things down. Block, again, if you just remember a block, you're fine. And then for your patients who have prolonged QT don't want to use this medication because then they're going to start building it up. Toxicities can occur. Then we will see increased adverse effects happening. And if that torsades is going to happen, it's more likely to happen now, right? Because I have more concentration of that drug in the system than what I wanted. So that's why that creatinine clearance is there. We will take a break and come back. Let's do 2. So 14, please.
Sure, but what's happening? And then out of nowhere, it is changed. And you're long out and you get wide. So if you had, if that happened, you get narrow fluorescence, then you're being jumped. So if you have wide fluorescence, now it's not gonna be, yeah, it's not gonna be like right, like that's right. You're dropping, like your body's not the opposite. So your pacemaker is working, and I know it's not working. Now your body has to. With the escape, that doesn't mean it's already at the stage where you're taking the so it just got used to it. Your body keeps calming down that flow. But if you recognize it, just change the normal time that you escape from it happening now that that's both the SA and the BB is no longer working.
Yeah, I know, but I want to be able to
Sure, but like just by looking at that, you become like look at that. And the thing is like you're also trying to count the loss. You're also trying to like tell people to look our way. Remember in the beginning to that, you have to count your QRS, you have to count all the way until what the S becomes the T wave. So your T wave is right there. So that's why it's not. It's not. You're not only counting that is just well. That's not the complex. That's our way. Your QRS complex. I mean, you don't always have a V. You don't always have a Q. You don't always have an S. That's why you always think of that just as a QRS. In this case, you do have an S because it says S comes down. That's your S. You have a Q there. But you know that's for stuff. I know. You can tell that's more. So don't try to get into the weeds of looking at that R wave, that one curve, what that box is, because that's not information. That's just R wave.
That's all right.
Yeah, did you get a cup? Hopefully I can make that cup.
That makes sense.
Oh, I should ask? The person who got 100? Okay, if I can get your point back in my hair. But for a friend, I don't want to ask.
My wife keeps drinking my latte.
So this is like kind of so right there, and then if we cross down,
On my side, dude.
No. Went down the wrong way. No.
No, my hair. Yeah, exactly. No, if the hair follicle is dead already, dude.
but
What? We gotta pay for the $10,000 lamp to work here. I have to like put lotion on my fucking head or sunscreen. Oh, dude, yes. That's what I was hoping you were gonna say. It's not going to log in this dude. No, it's all red.
You guys sing those. Make sure I
and because it's coming from the atrium, you'll have like two sets have that normal beat.
Shoulders.
The SA node is what causes the femur to occur. So without the SA node, you can't. Or you have a messed up.
I'm about to ditch this. Have that on.
Oh, I love life right now.
Yeah, that's what I don't think you are. I
feel like I'll show you after this. Well,
That was one free one. Yeah, when it was like that, I was like,
I had no clue. I was like, I know they need direct.
I remember I thought it was being right. It was one of his foot strokes. Yeah, I thought it was on the line for like, hey, you don't get that.
I had it was I was like, oh, you can really monitor it. One that one actually one that super cut.
You like that?
I couldn't even tell you what it was.
That was
Oh, mine. But
were you like birthday?
Okay. All right, starting with our ibutylide. So when you're looking at ibutylide, on that chart in the very beginning where I told y'all like all the drugs that are on here may not have a slide or vice versa, this one isn't on there, so just write it in on that other chart if you want to, but know that it's class 3. Mechanism of action, again, same things that we already talked about, potassium, right? All the other stuff underneath, reiterating again, I don't need you guys to remember that. If you remember those boxes on the first 2 slides where it was introduced, that's all I need you to remember, okay? So also slows inward sodium current, all of the stuff under, don't worry about it, okay? I got asked that a couple of times. Clinical use, atrial arrhythmias that our patients will be having, and then adverse effects, we see that they're proarrhythmic and that they can cause that torsades to occur, okay? So we're watching out for that. Dofetilide. Remember I told you put those 2 together, put your amiodarone and your dronedarone together. So dofetilide, when we're looking at this, clinical use, AFib, A-flutter, in our patients who are cardioverted, we can also use this. In our patients, if we're trying to get some normal sinus rhythm, and they have like some symptoms of flutter, you can see that this is used for those as well. Again, if they are highly symptomatic is when you see us using this. If we don't need to use these meds, especially our rhythm control meds, we don't want to have to use them. They are good for controlling any of the symptoms that your patients are likely going to be complaining about. Clearly, it's an oral medication, so you see we have good bioavailability. If there are some renal issues, because a lot of this is excreted renally, you will be needing to dose adjust for that, potentially even avoiding it. And then, just like we saw with our Solol, you see that I also have to have this patient being monitored. So monitoring their heart, making sure that you can resuscitate them if something goes wrong. Same thing like we talked about our Solol, okay? So monitoring them 3 days for us to start them. Contraindication, before we were talking about creatinine clearance that was less than 40, now we're talking about creatinine clearance that's less than 20, because remember a lot of that drug is renally excreted and we might need to dose adjust. Looking at your QT prolongation, I will just have, like if you see something and it's a higher QT, just you don't need to remember, oh this one says 440 and another one says 500 or 550, like I don't need you to remember that. QT prolongation is enough for you to know like, hey, it's longer. A longer QT. Drug interactions, there's several of them, so just making sure that you're understanding that you're going to have to run that interaction checker again. On this one, don't remember these specific ones because these aren't things that we're talking about right now. Just know that there's lots of different interactions, and what happens now, we were typically seeing where our drug was increasing the effects of the other drugs. Now we're seeing that our drug side effects here now can be increased by those interactions that we have with those other medications. So it's increasing the half-life of now my actual dofetilide. Adverse effects, torsades, we don't want it, so that's why they're in the hospital for that longer period of time. And then GI discomfort can happen. The higher the dose, the more likely you are to see this occur. Calcium channel blockers. We know our calcium channel blockers. So, mechanism of action, this one, please do look at the fact that you have that inward movement right, of your calcium coming in. So just that main big bullet, not all of these sub bullets for this one. So just remember your first top bullet of the laser. Just this bullet right here is enough for you to remember. And looking at this, again, the ones that you already know, so your beta blockers and your calcium channel blockers, we know that those are rate control, right? So rate control, you see that these are very good when we're talking about atrial and ventricular, but I am more effective whenever I'm looking at my atrial arrhythmias. And then looking at this down here, just if you know atrial, ventricular, but more atrial, you're good. Your cardiotoxic effects, so again, when you're talking about dose related, the higher the dose, the more likely you are to see this occur. So just understand that we have several different cardiotoxic effects, and we have those negative inotropic effects, so they're going to slow down that heart rate, right? Because they are rate control. So I'm slowing down the heart rate, so you can see this in your patients who already have bradycardia. If your patients are taking a beta blocker, remember those have those synergistic effects. So it's the same things that you've already seen discussed before on here. your hypotension, because you have some vasodilation that can potentially occur, and then your other typical things, GI disturbances, nothing really bad here. We're talking about our non-DHPs. Remember, which two drugs were your non-DHP? Rapamil and DIL, right? So you see that when we're looking at those, you do have more constipation, more GI issues when we're looking at our verapamil. It's a bigger offender and is a very commonly prescribed drug. So thinking about all of those side effects that we talked about, specifically with verapamil, comes into play also. This, y'all can cross this out. This is mechanism of action in more detail than I wanted you to know. So just go ahead and cross that out. Now, looking at the non-DHPs that we are talking about using in our patients who have arrhythmias, because that's what I'm focusing on, right? I'm focusing on their rate. So when I look at this, I have my verapamil that we're going to look at, and I have my diltiazem we're going to look at. We know that these are oral and IV medications, so I could potentially have my patient be hospitalized whenever I start these medications, but that doesn't necessarily always have to be the case. You see that here, you have more of your action on your heart than on your vasculature, right? Which is why we call these our non-DHPs versus looking at your DHPs, which are going to deal more so with the vasculature. So remembering the difference between your DHPs and your non-DHPs, and if we're talking about an arrhythmia where my rate is abnormal, I'm looking at my non-DHPs, right? I'm not worrying about my vasodilation, okay? So your PK effects that you have, renal excretion, all the things that you guys have already seen before, CYP interactions. Looking at your DILT is not as strong or as effective as we would talk about our verapamil. So less of that slowing down of the heart rate. Is it still slowing down your heart rate? Yes, but just not as much as your verapamil. So if you had a patient who had a very, very rapid heart rate, and you're like, I probably would want to prescribe verapamil versus your patient who is elevated and they're not within normal limits, but they're close to that goal, right? Then you can give them the DIL because it's going to lower them a little bit less versus if you gave them that verapamil, you can decrease that rate. Okay, so you can now they're too slow. Could happen. Or they're on the lower end. And if that happens, you will know because your patient's going to come in, they're going to start telling you that they are dizzy, that their blood pressure might be dropping, that they are, they feel like they're about to faint. Those are your hints that, hey, this dose was probably too much for my patient, and I need to increase it. Or I can change them to the diltiazem, because now that's not as potent, and I won't have as much of that bradycardic side effect occurring. Looking at this, though, compared to, so think about when you're talking about your calcium channel blockers, you have either your vasodilation or you have your slowing down your heart rate, right? When we look at a DHP versus a non-DHP, remember your chart that you had the arrows, and it was showing you the different effects and the potency of how dramatic their vasodilation would be with one over the other. So you're still going to get both effects from these drugs, okay? So when it's saying, when you're looking at your diltiazem, it's saying that, hey, this is a more potent vasodilator than your verapamil. But your verapamil, you're going to get more of that cardiac slowing, or the negative inotropic effect, okay? So just keep those two in mind. Same things when we're talking about our PK parameters, just understand it has interactions. Okay, these are drugs that some people will call these class 5, which they're not really a class 5, but these are not classified by our Vaughan-Williams system, and therefore they're kind of like the ones that are out to the side. So the way that I remember them is the acronym DAM, like we just left them off, right? So it's going to be DAM when we go through this, okay? Digoxin. Digoxin is an old medication, and no one loves it, except for maybe cardiologists, because there's so much monitoring. It's a narrow therapeutic index drug, but guess what happens on your pants? Guess what's going to happen on my test? You're going to see it. We love to test over digoxin. You're going to see digoxin. You're going to see patients who are on digoxin because it is still a very effective drug. It is good at what it does. So when you're looking at your digoxin, your mechanism of action here, you see this a cardioglycoside, and essentially what it's doing is like making that patient dig deep, right? I think about digoxin as like digging deep so that I can increase the force of my contraction, okay? So positive inotrope, remembering what's in purple is very important for you guys so that you understand your mechanism and how this is working. So when you're looking at this, you see your sodium and your potassium ATPase of the cardiac membrane being inhibited. So we're going to look at a picture that's going to talk about this, but whenever you're looking at the action potential that we kind of went over, we push potassium out against its gradient and sodium in against its gradient, right? So that's why we have that ATPase to do that, because it's not following its natural gradient. It's going against what its gradient is. So when you inhibit that exchange pump, now you have more sodium inside and more of your potassium outside, and then your calcium is going to start to increase because there's decreased function of another pump, which is going to be your calcium and sodium exchanger, okay? So that's where you see increased intracellular sodium and calcium. That's because there's another exchanger, and that's an indirect effect that is happening from digoxin blocking your sodium and potassium ATPase, okay? So this happens, and then you see an increase in your sodium and calcium on the inside. So think about how you tell people, like, right, more calcium, things are stronger, right? We think about calcium making things stronger. So if I have more calcium now intracellularly, now I can see why I have a stronger pump, right? That stronger contractility, because I think about calcium now being inside. So just kind of keep that in mind. So the calcium is inside. Now digoxin, I can dig and make a stronger contraction, which is what I'm wanting to do. The AV node blockade, essentially that's just saying, hey, let me try to slow down that signaling that's happening, and therefore I can slow down my heart rate, and that's why this also falls into our rate control, like our beta blockers and our calcium channel blockers did, okay? So this is, again, trying to get everything under control so that that person can have that arrhythmia be terminated. Do you see this? Yes, you can still see this. Is it very often? No. Are you going to be tested on this? Yes. Okay. This is a picture of what we just talked about. So you can see that there's an increase that's going to happen in the tone with the force from the calcium. So therefore, you're going to see a net increase in your cardiac output that's happening, which is what we were trying to get from this patient, right? Because if I'm quivering, if I'm not having a complete contraction, that blood is not flowing how I want it to. When I'm giving this, I can get that blood flow, and then remember, I also have that benefit of slowing down the conduction with at that AV node, okay? So when you give too much of digoxin, which is a narrow therapeutic index drug, because we do have that blocking, that's how you can see it can lead to death, because I blocked that transmission of the heart, right? Now that signal isn't happening. So when I'm looking at this, too much now has blocked so much, right? I've blocked my AV node so much that I have no conduction anymore. When your heart stops, you stop, all right? Clinical use. Oh, what do we see there? Heart failure, right? I already talked about it a little bit, but not as in depth. And then our AFib and our A-flutter patients, you can also see this use. When you're talking about this and the fact that it can trigger a tachyarrhythmia, you can see that some of our patients who are not stable and have heart failure, they can have an increased risk of mortality in those patients. So that's why in our heart failure, we were trying to maximize our backbone before we put this on. This was like that additional control that we needed, but not the first thing that we were going to run to in these patients. So make sure that you're remembering that. Your PK parameter, good distribution, half-life is normal. But if you're talking about somebody who has any renal issues because it is renally excreted, or if you're talking about an elderly person, because remember how I always tell you guys, like, they live and their body usually starts to, decline and things stop working as well in most people, not all people. So you can see now, if I've decreased my renal clearance, what's happening to my concentration of the drug, up or down? It's going up. So if I have an increase in that concentration of the drug, what am I now worried about? Toxicity, side effects. They're going to be a bigger problem for me now. And I told you guys, narrow therapeutic index drugs, right? Bless you. So if I'm at a narrow therapeutic index and now things aren't working, or I gave a drug that interacts with it and it's affecting that concentration of my digoxin, now instead of me being in this window, I'm up here, right? Now that I'm up here, I have digoxin toxicity, which we don't want to see. So, looking at your therapeutic levels, we like to see our patients between 0.5 and 1.5. When you're looking at this, make sure that you're understanding that one dose that could be given to me may not be the same that's given to you, your neighbor, and so on, okay? So you're monitoring your patient because most likely these patients are going to be on other drugs that may likely also interact with your digoxin. So you're going to have to tailor that dose to that patient and let that patient know if they change anything, kind of how we talk about warfarin with their diet. If they change their diet, we need to know because their warfarin levels are probably going to change. Same things happen with digoxin. If they stop taking anything or if they start taking something, we need to know because it could potentially affect their levels. So you see that we kind of start slow. So we start low, go slow. And then if your patient's symptoms are not controlled, then you will see where we start to slowly increase this dose. I don't need you to remember like all of the different doses. I just want you to know we're starting slow and low, okay? And if our patient isn't improving, then we will slowly start to increase that dose. Dose adjustment, we already talked about that renal dysfunction, right? So I might have to dose adjust, so that makes sense while we're starting slow, especially in my elderly patients, especially in my patients who might have any type of renal dysfunction because I'm trying to make sure that I'm not overdosing them. A bigger person versus a smaller person, right? Like that smaller person should not be taking the same dose, likely, not taking the same dose as the 6'5" person, right? Me against that person. My dose is probably going to be lower. And then looking at your labs, you're going to monitor the labs. Again, if anything changes, when you're initiating this dose and you're trying to figure out if your patient is within that therapeutic window, you're going to continue to monitor those labs until you get them on their established dose, and then you're going to say, all right, we got you in that target window of that 0.5 to the 1.5, and therefore I can leave you here. Most of the time we will try to shoot for the middle. You don't want to be too low because if something changes, they forget one dose. Now they're out of the therapeutic window, they're not controlled. But we don't want to be on the very high end if we don't have to because they take one thing that interacts with that drug and now it's bumped them out of the window and we have toxicity. Monitoring. The monitoring that we're going to do makes sense because we talked about monitoring all of these things anyway. So when we're looking at our patients, they come back in and they're on digoxin. You're always, in any of these medications that we're talking about, you're always getting that ECG. Your digoxin level, you're always pulling that whenever they come in. But make sure that you're not doing it as soon as they take the dose. Because what process do I have to go through that we talked about last semester? Got to go through ADME, right? So I have to absorb it, distribute it, metabolize it. Elimination, we're not really, but we're trying to see, hey, what is that dose after they've taken it? If I just swallow the pill, you're not going to see anything. My body hasn't broken it down yet. So it's telling you to make sure that you at least wait for that 6 to 8 hours before you try to pull a level because you're not going to have anything. And then your electrolytes, what's the big electrolyte that we were worried about? Potassium, right? So make sure that you remember that potassium. Your blood, urea, nitrogen, creatinine, again, that's also by way of the fact that the patient, if they don't have good renal clearance, the big thing with the creatinine, they don't have good renal clearance, then we're worried about that buildup. Another thing that you need to make sure that you write in for me, because I don't see it here. If somebody has a heart rate that is less than 60, we're not going to start this medication, because this medication is very good at what it does. And this could potentially kill somebody, right? Because now I've made them more bradycardic because I'm blocking that signal. Don't forget that I'm still blocking. I'm getting a good squeeze, but I didn't say that I'm not still slowing things down, right? So if I'm less than 60, and I'll post it and put it on here, but if I'm less than 60, make sure that you understand you are not starting this med if my heart rate is less than 60. It'll get it work, okay? Everybody tracking? Yes, yes. I'll post it as well. Adverse effects. Every drug comes with some not that bad. Very basic things, right? What we don't love here, and again, our elderly patients are the ones who are likely to be on this medication, but our elderly patients are also the ones who have some of these side effects at baseline. Altered mental status. Okay, this could make that worse for them. And then these visual disturbances that you can see. So the visual disturbances are, they can see, they'll have like blurred vision. They will say that things have like a yellow hue to them whenever they're looking at them. So that's your hint to say, maybe my dose might be a little bit too high. Let me pull some levels and see what's going on. And then even if you're within that range, you might need to lower it for that patient, right? They're not tolerating it well. There might be other things going on where they're clearing it. They're not clearing it well. So you will see that when you pull that lab. But again, this is for you to know, I might have to change some things. And then greater than 2. When you're greater than 2, you're in deep poo-poo, okay? That's how I remember what number. Greater than 2 means that they have gotten way outside of that window where we want them to be. And remember, narrow therapeutic index drug. So now you're more likely to see those pro-arrhythmic effects that we talked about. We don't want that. So you'll start to see those arrhythmias that can eventually end up leading to cardiac arrest, which is death for your patient. Some of the signs that you'll see are all listed here. Now, instead of having just kind of like that little yellow tint to things, they say that it looks like a halo, a yellow halo around everything. Okay? They're about to see God or whoever they're going to. All right? That's how I remember that. They see yellow halos. Okay? Because we have them now outside of that toxic window. Okay? So over 2, deep poo-poo, visual disturbances are now more pronounced. You're going to see a lot of GI upset. Hopefully your patient is there. You'll see that hyperkalemia, right? Because now those levels have gone up very, very high. It does so make sure that you're paying attention to the fact that when somebody is older, because of the electrolyte disturbances that they can potentially have, you will see that the risks that are down at the bottom bullet, those are risks that increase the chance of them hitting that toxicity, okay? Versus when you're looking at, hey, I can have all of these other issues occur if I have toxicity. So this is just like risk enhancers of them hitting that toxic state sooner. When you're looking at your hyperkalemia that can happen, that's essentially because you have the displacement that's occurring when we were talking about all of the different pumps that are being affected when we're looking at the mechanism. So just pay attention to that as well. What else did I want you to remember for me? Those are the big things. So remember your big electrolyte that we're always looking at is our potassium. Drug interactions. Lots of interactions when we're talking about our digoxin. These are the things that you're likely to see whenever you're getting tested on them. And then the fact that those adverse effects, people are typically very specific whenever they're asking you about digoxin and those adverse effects and the halos. So decreased absorption of things that we typically think would block absorption anyway, right? So your antacid, laxative, cholestyramine, these are the things that we always would tell our patients, like, hey, separate them out from when you're taking your drug because it can decrease the absorption of your drug. So this is the same thing that you've already seen, just kind of always group those together, right? Increasing your digoxin concentration. So if you are starting one of these meds, which is where I was telling you, this is kind of where you come in because these are medications that you could potentially be prescribing and not even thinking anything of it. Are you going to likely start digoxin? No. Are you going to see a patient who's on digoxin? Maybe. So if I'm giving one of my macrolides, my antifungal, my class 1A, which are the drugs that we just talked about, you can see where you can have that digoxin level be increased, sometimes because of the clearance of the drug it's been decreased because now it's competing for that clearance. So just please, please, please make sure that you're looking at your macrolides, your antifungal, your class 1A drugs, and then your others. So your cyclosporin, tacrolimus, and verapamil are there. Anything that affects your potassium, because remember, we were worried about our potassium, and that was the one drug or one electrolyte that we kept monitoring, we're always looking at. So anything that affects your potassium levels, right? So like our loop diuretics, things like that, make sure that you are keeping an eye on those because they can again affect what my digoxin is doing. And then also, if I am giving it another drug, our calcium channel, our non-DHP calcium channel blockers, my beta blockers, anything that's going to slow down that heart rate, if I'm giving that with the digoxin, again, they have the additive effect. So anything that we're talking about today, think about if I give it with a non-DHP calcium channel blocker, all of them are going to be adding on, right? Because they're all slowing everything down, which is the name of this lecture, right? We want to slow down their heart rate. Looking at our contraindications. So these look very, very familiar to what we have already seen. So your patients who have VFib already, it's there. Your heart rate that's less than 60, the one that I told you right before. So we're not going to start this medication if it's there. Hypokalemia, your WPW syndrome. So when you're looking at this, it goes all back to the mechanism because of that sodium, potassium, ATPase pump. That is all why you see these contraindications. So if they already have hypokalemia, we would just be making the situation a lot worse. Looking at your electrolyte levels of digoxin. So this is telling you, and you're likely to potentially see something like this, I don't know. What's happening if your patient has hypokalemia versus what happens, bless you, if your patient has hyperkalemia. So my potassium is competing with my digoxin, right? My drug that I have introduced, this is endogenous, right? It's already there. For the binding sites to this thing that we already told you your digoxin is working on, so your sodium, potassium, ATPase. So if my patient has hypokalemia, now I can have no competition, right? Hypo is less potassium that's around. So now there's no competition. Your digoxin is like, hey, I can go where I want. I'm binding to that ATPase, right? So therefore, you see increased effects of your digoxin because you have low levels of potassium that's there to compete with it, right? Everything is open just for your digoxin because I have low levels of potassium. So again, signs and symptoms are the same things that we told you that we can potentially see. You'll also see that now they're not monitored. They have an increased risk of those arrhythmias because now I'm in my toxic level. And remember we said in my toxic level, I have more blockage of that AV. So that's why you see now you have that pro-arrhythmic cycle happening. So the VFib and then potentially death if we are not able to catch it in time. Then when you look at your hyperkalemia, now I have so much potassium around that's trying to compete with the digoxin, and therefore now I'm going to see decreased effects of my digoxin, right? So now it's not going to be working as much, okay? So make sure you're understanding what's going on with your hypo and your hyperkalemia. What do I do if I see this happening or my patient comes into me because it's easier for them to get to me than their cardiologist? So what did we say was too high? What number? Two. Greater than 2. So if I'm greater than 2, I'm like, oh, great. Or if my patient is exhibiting signs and symptoms of all of those things that we talked about with the toxicity, then I want to stop my digoxin for a couple of days, and I'm going to get a level after I have stopped it. I'm going to be monitoring this patient. There are some situations where you will see that we restart the digoxin. We may just start it at a lower dose. You also have to ask the patient what's going on, because let's say I'm an older patient. I didn't remember if I took my digoxin today or not, right? And so now I took an extra dose of what I needed. Sometimes there are circumstances that have caused this to happen, and sometimes there's not, right? Did you change anything? Did you start another medication? Like, ask those questions before you just say, I'm going to discontinue the digoxin and never put them back on it, okay? So looking at what you're supposed to do, you can give them digoxin immune fab. And even in the brand name, it tells you what it's doing, Digiline, okay? So that is your antidote to if somebody has very high levels of the digoxin. So what it's doing is it's trying to bind to the digoxin and make it to where it's not free anymore, right? Because now it's bound to your Digiline, and now we're going to get rid of it. So again, That potassium is back, right? Make sure that you're monitoring it because now you could potentially have hypokalemia occur. Because what happens is it starts to shift back into the cell, and that's where you can see sometimes this why we're monitoring our potassium levels. So we did our D, now we're on A, adenosine. So when you're looking at adenosine, make sure that you're paying attention to the mechanism of action. Now this isn't as broad as what we saw when we were looking at our Vaughan-Williams, right? So we have adenosine naturally in our body, but what this is doing is increasing our potassium, decreasing the calcium that we have as far as our influx. So increase potassium efflux, decrease calcium influx. Remember that your calcium was in phase 2 where we were like about to hit that plateau, and that's where we also use our calcium channel blockers sometimes. It's kind of hitting that area too. So you see the hyperpolarization that occurs, and then you're trying to say, hey, let me decrease that conduction. Let me slow things down, and this is where we try to see where our patients will, if they are out of rhythm, we can potentially get them back in rhythm whenever we use our adenosine. When you look at your clinical use, regular rhythm of PSVTs, okay? So if somebody has a PSVT or paroxysmal supraventricular tachycardia, we will try to use this. And you see it says acute conversion. So this medication has a very, very short half-life. So I think about that, and that's how I remember that it has a very short half-life because it's used in that acute situation where you're needing something right now to try to terminate that PSVT. Only used in emergency and acute situations. So remember, it's a short half-life. Adenosine is quick, okay? Along those lines, what you're doing whenever you push adenosine, you usually have your flushes that you're going to use after it, and you're using both hands when you're pushing this medication. Because the half-life is so short, once you've pushed it, if you don't flush after it, the drug doesn't make it to the patient, or if it takes too long to get there, now it's already not, like by the time it hits them, it's not working. So we did this in my residency to a patient, and I kind of liken it to like turning off a light switch real quick and turning it back on, right? So the resident pushed it, and the patient was still looking at us, and the doctor goes, hey, like, did you feel that at all? And he's like, oh, no, I thought this was going to be very bad. He's like, oh, it didn't make it to you. And so we doubled the dose, which you'll see here in this dosing. This is one of the doses that I do want you to remember. I don't ask y'all to remember a lot of doses. This one, I want you to remember this dose. And so we did it again, and he, like, passed out, and I was like, oh, my gosh. And the doctor was like, okay, he's coming back in a second. And then he came back, and he's like, oh, my gosh, that hurt really bad. So essentially what we did was we turned off his heart and then turned it back on, okay? So I think about adenosine, super short half-life. But what happened the second time was, as soon as the doc pushed, he's like, flush, flush, and like they did it right away. So you have to be ready to flush as soon as you put that medication in, or it's not going to get to your patient, it's not going to work. It is nice for you to give them something to help with pain. Do you have to give them something to help with pain? No, but you should, okay? Sometimes there may be a situation where we don't have time to do that. So looking at your dosing, right, 6 milligrams is where we're starting out with, and if that doesn't work, then we double it. So that's what I told you, we doubled it. Doctor talked to the patient, kind of calmed him down. He was like, okay, this time you're likely to feel it. It is going to, hurt a little bit, but we gave you some meds, so we gave him his meds, and then we did it again, and he was fine. So your adverse effect, it's what we want to see, right? I turned it off. So asystole is happening because I turned everything off. I'm trying to reset it because it is beating super fast, and I don't want that to happen. My person has PSVT, so I gave them this adenosine. I had to quickly flush after it. My adverse effect is that it stopped, right? I want to see that happen. And then think about the person. I just remember him, and he was like clutching his chest, and he was like, oh, that really hurt, right? So your other adverse effects that they have, the tightness, the shortness of breath, that's just because their heart was off, and we flipped it back on, okay? And then the flushing, again, because of that short half-life, if you do have a patient who experiences it, it's very quick. It's going to wear off very soon, so you're not really like trying to do extra things to treat for that. Interactions, if you have theophylline, if that patient is taking that, then you're not likely to see the effects of your adenosine because it blocks that receptor that your adenosine is binding to. So just keep that in mind. Make sure that you're keeping an eye on it. Do people typically, if we're reaching for this drug, are we really worried about it? No, they'll just be like, oh, well, let me start with 12 instead of 6 milligrams. Like I need to probably increase that dose. And then your M, right? So we did digoxin, adenosine, now we're at our MAG sulfate. When we talk about MAG sulfate, again, this is blocking those neuromuscular junctions and trying to compete with that calcium to make it not as excitable. So if I do that, then therefore I'm decreasing and relaxing things. So I think about this as like kind of like an antagonist in my brain. You see that we also get some vasodilation, some CNS depression can happen. We talk about this and we'll look at this when we look at like preeclampsia and things like that, and if somebody has a history of it and they're about to deliver, we have sometimes we'll push the MAG sulfate, bless you, when they're about to deliver their child. Looking at our clinical uses, so eclampsia, preeclampsia, hypomagnesemia, asthma, and then your tocolysis. These are things that we don't really see it used for. Most of the time you'll see us using this for the seizure prevention. And then if somebody has a deficiency, you'll see us use this, especially if they're in an inpatient setting, right? Because I can quickly do this to them and let it go. Yeah.
And is this the same as the liquid magnesia that we know about?
No. So your milk of magnesia, you're using that whenever we're trying to get people to, we were talking about that in GI. When we're looking at this is more dealing with like CNS type issues, or if you're just looking at magnesium deficiency in general, it's you replacing it. So it's a different, what is the word I'm looking for? It's a different salt, not the same exact thing. Okay, bless you. Pour oral, so that's why we see that it's not PL formulation. And then adverse effects, flushing, low blood pressure. You can hear some people talk about the nausea and vomiting. It's kind of hard to distinguish that between the indications that we're using it for. You can also see some arrhythmias occur. Usually this is at higher doses, same thing for that respiratory depression. And then if I gave them too much, you're likely to see that those levels now have gotten high of their magnesium. So monitoring their electrolytes and their renal function. You're monitoring for that hypocalcemia because that has some antagonism of calcium. So that's why we're monitoring for that, the calcium levels. And then looking at our interactions, again, calcium channel blockers, digoxin, other CNS depressants, anything that can cause hypertension, anything that could be pro-arrhythmic, so like our class 1, our class 3, any of our drugs almost that we talked about, you could potentially see additive effects when you're using the MAG sulfate in addition to. Remember, these are the ones that are like further down, and because they're IVIM, that means your person is like they're hospitalized. This is again one of those drugs that we're not giving to the patient to do themselves at home. All right, now looking at my arrhythmia treatments, all I want you to know is what is in this box. We have different types of arrhythmias. You have your paroxysmal, persistent, long-standing, persistent, permanent, and recurrent. When you're looking at your paroxysmal, this is like sometimes your patients will have it and then it just randomly will disappear and they don't ever experience it again. Your persistent is something that lasted longer than a week. Your long-standing is something that lasted longer than a year. And your permanent is like it continues to happen. You can't cardiovert that person, or they talk to you as a provider and they were like, I don't care, I want to stay right here. Okay? So those are the different types that we have when we're looking at our AFib. So this is all going over atrial fibrillation right now and how we could potentially cardiovert our patient. So pay attention to the box. When we're looking at cardioversion, we have an electrical cardioversion and we have a chemical cardioversion. When you're looking at this, I kind of think of this, right? These are our different forms of cardioversion. I can put my, you shocking somebody, right? That's going to be your electrical, and your chemical is me. That's medicine, right? That's our drugs that we're taking and we're putting in their body to try to get them back into normal sinus rhythm. So, if your patient is thinking about cardioversion, either route, you see that they've been having, and they've had AFib for over 48 hours. we want to try to anticoagulate that person because they have been quivering, like how we like to say it, for over 48 hours, which means that blood has not been flowing how it should. And now it's probably clotted. Do we know? No, we don't know. So that's why some people, we will just say, hey, I'm going to anticoagulate you before I cardiovert you. If a patient doesn't know how long they've been in AFib, better safe than sorry. So we would anticoagulate them first. Anticoagulation is a choice of the patient. There's another option, which is your transesophageal echocardiogram, or your TEE. This is a procedure that they will have to do, and they will be in the hospital, but that is a patient decision along with you educating them. So if you do the TEE and you don't see a thrombus there, then you can go ahead and you can cardiovert. If they decide not to do the TEE, then you're going to cardiovert them before they have that, you're going to anticoagulate them before you cardiovert them, okay? And then no matter which route they take before the cardioversion, most of the time we are going to anticoagulate them after the cardioversion because they may not stay cardioverted, right? Remember I said sometimes those cardioversions work and sometimes they don't. So sometimes I can get them into a normal sinus rhythm and randomly, maybe a week, 2 weeks, 3 weeks later, maybe I now went back into that bad rhythm, okay? So we still kind of try to maintain them to make sure that we keep them anticoagulated while their rhythm is trying to figure out what's going on. And it helps us maintain that rhythm. So here are the things that we have that we could potentially use to cardiovert our patient, right? So we had our rate control drugs that we talked about, and then these are the rhythm control drugs that we will use when we're talking about our cardioversion. Then we have our anticoagulation, which is some of the things that you all have already gone over. So you have your aspirin or your DOACs or your oral anticoagulation. So when we're looking at this, you see that we like to anticoagulate more with our DOACs because we don't have to monitor as much as if we were to anticoagulate them if they were on warfarin. So our DOACs, our 10A, are the ones that we typically like to use. So you see your, except for this one, but you see your dabigatran, your rivaroxaban, edoxaban, and apixaban. And then your warfarin, you see that we're going to give them this dose. We're titrating it to our INR. So you're going to monitor them, make sure that their INR hits that 2 to 3 range. I just need you to remember warfarin. I don't need you to remember what the INR is. And then you see your heparin and your aspirin. These two are like rarely used. So anytime you see AFib, your thought should be, I need to get a CHADS-VASc score. Your CHADS-VASc score is a calculator that they have online. You will go to that and you will put in the patient's information. It's going to spit out a score to you. So these are all of the different things that you're giving them a score for. You can either put it, they have calculators for it. You can also carry around a card, and you can do this yourself because you see it's just a couple of points based off of these disease states or clinical issues that they may have. And some of them aren't an issue because like you see here, being a female, they automatically get a point, right? So some of these things you just go through and you say, hey, everything gets a point except for if they're over the age of 75 or if they've had a history of some type of stroke, then those are the only that have 2. So that's what you see in this name. The CHADS-VASc is telling you all of the different data that you're going to have to obtain from that patient. I don't need you to remember what CHADS-VASc stands for. All I need you to remember is what's down here when you're getting your score. So this is a boy, this is a girl, right? Don't laugh, I'm telling you for real. So if it is a male and their score is 0, if it is a female and they are 1, because remember, just because I'm a female, I'm already getting a score of 1, right? Does not mean that you have to anticoagulate your patient. This will be something that is like if somebody has very high risk, all of the things, that's when you'll start to think about that. But this is just looking at face value, and if I ask you about this, I'm asking you at face value. So 0 for a male or 1 for a female, we don't need to anticoagulate, right? So you don't need to anticoagulate. If you are a 1 for a male and 2 for a female, now we get a little rocky, right? I may need to anticoagulate that patient. If I am over 2 for a male, over 3 for a female, you have too many risks for me. I am going to anticoagulate that patient. I'm going to recommend that they get on some type of anticoagulation, okay? So, this is what you are looking for. So know that, remember, male versus female matters, this is their gender at birth. And then you're anticoagulating likely with a DOAC or with warfarin. Preferably a DOAC, but there are situations, right, that we have to use our warfarin instead. All right? Everybody good? Okay.
Ma'am,
Yep.
I'm sorry, just
Yep.
way that this is written on here, DOAC superior to warfarin preferred, does that mean that DOAC is, or,
Preferred
okay, preferred
DOAC is
to warfarin?
to warfarin,
Okay.
yes.
Sure.
So that's why I put this one first and then this one second. This is actually like in order. We don't love warfarin because it makes you work too much, right? It's putting extra work versus me giving them the DOAC. I don't have to monitor as much. All right. So our ventricular rate control. Again, our goal, trying to decrease, right, that stimulation that they're having. Most of the time when we're talking about our digoxin, just like we talked about before, last block, you're not using this by itself. Most of the time this is added on board because they are not maintained very well with things that are in our Bond-Williams classification system. So again, effective if you need some additional heart rate control. These patients are probably on one of these medications already, and it's not working. Because remember, these were already in our Bond-Williams. So again, think about that class 5, our DAM, that's extra, okay? And then avoid in our patients with WPW, they have an extra pathway, like their heart has made an extra pathway, and so they're usually they're tachycardic, and it can make their syndrome a little bit worse. Looking at our ventricular rate control, so we already talked about what we use for our rate control. You have your beta blockers, you have your non-DHPs. When we're looking at our beta blockers and when we can use them to get some of that treatment for our patients who have AFib, you see that we're good with controlling our exercise, induced heart rate increases that we're having. So this is where your patients are going to likely experience some symptoms, and therefore you can prophylactically sometimes treat our patients with them, but most of the time our patients are going to be on these daily, every single day they're going to be taking them. Can be considered in your patients with your stable heart failure. Again, we talked about these that we were using in our heart failure patients, your CBM, right, that you had. And then your adverse effects, same thing we already talked about with our beta blockers. Non-DHP, again, same things that you're already talking about before. Could potentially be preferred if somebody has like a respiratory issue as to why we would go to a non-DHP over a calcium channel blocker, but most of the time you will see providers still try to start with a beta blocker and monitor the patient to see if they have any type of bronchoconstriction occur. So when you see the bronchoconstriction thing with your beta blockers, will you see people who have asthma and COPD on a beta blocker? Absolutely. So don't think that like the provider is like killing the patient. They're probably closely monitoring that patient, okay? And then you just need to be aware. If you start to notice like, hey, did you notice that you've been using your inhaler more? Hey, have you noticed these things, and asking those questions? Then that's when you can dig deeper and be like, hey, maybe we need to take them off of the beta blocker and we need to rate control them instead with a calcium channel, the non-DHP calcium channel blocker, okay? We will start here. I was trying to get y'all out early tomorrow, but y'all have class. So we will start here tomorrow, and then right after I'm done, we will start